We are concerned with the human diseases. A significant subset of human disease. Also, I think you will be acquainted with the terminology called communicable diseases. Communicable disease means a disease which can spread from one human being to the other. Most of the communicable diseases are also infectious diseases. Now, what are infectious diseases? Infectious diseases are diseases which are caused either directly or indirectly by the organisms, various organisms. So, in today's class, we'll look into how we approach to the diagnosis of infectious diseases. आपको पता नहीं जानते प्रैक्टिकल क्लास আছে তোমার এক্সকিউজ কি Okay, now when I'm saying that this disease is actually the result of acquiring an organism either directly or indirectly, and the resultant events lead to disorganization of the normal homeostasis. That is what we call as infectious disease, right? Now, a very good feature of infectious disease is that if we can get rid of the organism in the first place, we can cure the patient. So for that, we need to know what is the exact organism which is causing the disease, how it is causing the disease, the pathogenesis behind it, and how we can eliminate the disease, either from the patient, from the community, and if in the best possible case scenario, we can eradicate from the world. A very good example would be smallpox. As of now, it has been eradicated, right? So that would be the ideal condition. But when we look down at the various organisms which cause human diseases, we understand that these organisms, they do have a source, a reservoir, and the host. Okay. So the organism, either from the source or reservoir, get attached to a person, in this case a human being, who is a host. And when it gets attached, it causes the disease. Okay. After that, the patient comes to your clinic with various signs and symptoms and complaints. I'm having fever or pain, etc. and etc. And then you think of a particular disease. There comes the question, what next? After that, what we have to do? We have to pinpoint the diagnosis at the exact causation. And after we get a confirmed diagnosis, we also need to treat the patient. That is of the foremost importance, right? So in today's class, we'll basically look how we are going to approach it. Okay. Now, the very naming of the subject comes from microscopy. Now, what is microscopy? Something that cannot be seen by the human eye. এখন কোথায় ক্লাসের টাইম কটায় সরি sit down. Next day onwards, I will not allow anybody to enter after 5 minutes after 2 p.m. Okay? Have you understood? So, human beings can see objects which are, that is 4.4 millimeter. Anything smaller beyond that we cannot see. Let us look at the history. Perhaps the first microscope, that is a compound microscope, not the lens, was made by Zacharias Janssen or probably by his father. Thereafter, a very important concept came about, what is known as resolution. Don't try to get into the depths of what it is, just try to look at this picture. These two pictures. What is the fundamental difference between these two pictures? In this picture, the two dots are overlapping, whereas in this picture, apron go there. You are in second year, right? This is not the first time you are entering the practical classes. Get inside. And in this picture, you can see the two dots clearly distinctively different. So what is the main difference between these two pictures? Anybody? You have to interact. This is a group discussion class. This is not a lecture class. What is the basic difference between these two pictures? We can basically clearly see the gap between these two. That is the resolution. When we cannot see them, we can perceive it as a single object. So at the end of the day, microscopy, or what level of microscopy we can achieve, is determined by resolution. That means the ability to differentiate between two points. Now, Anton van Leeuwenhoek, I think you already have learned about this. He was one of the eminent persons who had shown the discovery of a cell by the cork. Next, Robert Hooke contributed in further development of the microscope so that we can actually place some samples, that is the stage, with illumination and can be observed much easier. So that was the origin of what is known as a compound microscope. Compound means more than one lens being used. So from 1595 we have the light microscope. After that, in the 19th century, we have what is known as phase contrast microscope. What is phase contrast? With a different aperture, we differentiate the phases of the light that is actually illuminated. Hence, when two phase lights in two phases illuminate a particular object, we can actually see the outline. A very good example would be, if you have seen pencil drawings, there is an outline drawing, and in some drawing there are shading of various grading. So when a drawing is being shaded, even with a pencil, with that is only with black color, but various degrees of shading, we can see the more livelier picture. The same picture becomes more livelier. That contrast is created by shading. Similarly, in phase contrast microscope, when lights of different phases is allowed to come in contact with the object, we can see the same light in different phases. Hence, we can get a better contrasting view. Okay. So this is only an introduction class. This is only an introduction class. So we'll talk about the other types of microscopes later. Next comes what is known as the transmission electron microscope, that is the electron microscopy. Then comes the scanning, which is more a different type of electron microscope, confocal, and till 1981 we have the scanning tunnel microscope, and there are many other types of microscopy also, including atomic force microscopy. Okay. So this led to the development of this branch of medical science, and with the advent of microscopy, we started discovering more and more pathogens which are capable of causing human diseases, from worms to parasites to protozoas to bacteria. And after the advent of electron microscopy, we have even a different branch of disease caused by viruses have also been identified. Now, If you have heard, right after the terrorist activity or attack on 9/11, I think you have heard there was an incident that was happening in the United States. People were getting mail, and in those mails they contained white powder, and when they were opening the mail they were inhaling the powder, and that resulted in what was known as anthrax, or more specifically pulmonary anthrax. The spores of the bacteria were made a type of terrorism with biological elements, hence called as bioterrorism. Now, this leads us to the very important concept of what is biosafety and what is biosecurity. Now, biosafety means it is defined as use of, look at the definition, it is a typical definition: use of specific practices, training, safety equipment, specially designed buildings to protect the worker, community, and environment from accidental exposure of unintentional release of infectious agents and toxins. So, in gist, what does this definition says? Whenever we are handling with any biological agents which are capable of causing human disease, we have to do the activity in such a manner that the people who are working there, they are not affected. That biological agent should not come out from that working area to the nearby places, and above all should also protect the community. A very good example would be COVID-19 pandemic. All the evidences suggest that it started from a lab, spread it to local community in Wuhan, from there it spread to China, and then throughout the world. So biosafety basically means we have to take some steps so that this kind of event does not happen in the first place. Okay, so because we are dealing with human diseases caused by some biological agents, so we need to handle those biological agents. Now we know they can cause disease, so we need to take some specific precautions, work in specific methodologies, so that those biological agents do not cause infections in other people. Then comes, what is biosecurity? Is it the same thing? The answer is no. Biosecurity is defined as the protection, control, and accountability of high consequence biological agents and toxins and critical relevant biological materials, information within laboratories to prevent unauthorized possession, loss, theft, misuse, diversion, and international release. What do you infer from this definition? Biosecurity is a holistic idea. Okay. For example, the WHO has a holistic idea of providing health to all world civilians, right? But even in WHO, we have specific programs which address a specific part. Okay. Similarly, biosecurity means it's a holistic attitude. Another terminology that you should know is what is biohazard. Now, what is an hazard? Something that is injurious to a human being. And if it is biohazard means hazardous agent which is a biological nature. So what are being classified? They can classify into bacteria, fungi, parasites, viruses, and even biologically active substances like toxins and prions. Prions are proteins which, if a person acquires, can cause various types of illnesses. Okay, that those are not living organisms, yet they can cause specific diseases. These toxins could include a bacterial toxin, a fungal toxin, it could be even venoms, scorpion toxin. Okay, so these all biological agents come under biohazards. The CDC, you have heard about CDC, Center of Disease Prevention and Control, that is in USA. Even in India, we have NCDC, that is the National Center for Disease Prevention and Control. Now, CDC, they have classified some organisms into three categories, category A, B, and C, which can be used for activities like bioterrorism. Furthermore, there is a committee, Advisory Committee on Dangerous Pathogens. What they have done is they have classified all the known biological agents which can cause human disease into 4 categories. What are those categories based on? Based on how dangerous each and every organism is. For example, say if there is a parasite or a worm, if you don't come in contact with them, you will not get infected. However, if you get exposed to a person who is suffering from, say, varicella, that is chickenpox, and that person sneezes or coughs, it is a very high probability that you may acquire the infection. Okay, that means infectivity increases. So they have divided into 4 groups. The first group one is unlikely to cause human disease. The second group are all biological agents which cause human disease, may be hazard, but there is an effective prophylaxis or treatment. We know the organism. We have some antimicrobial agents which can be used to treat and control. Third group is which cause severe disease. Furthermore, it has a high propensity to spread into the community. But still there is a effective treatment or prophylaxis available. And finally, group D includes which causes severe disease, can spread to the community, and we do not have an effective treatment or prophylaxis. Okay. By this way, they have classified these 4 organisms into 4 categories. And similarly, they have suggested that all the laboratories which handle biological agents should be classified similarly into 4 categories: biosafety level 1, 2, 3 and 4. So when we are talking about biosafety level 1, that means we are handling biological agents which have a very low probability of to cause human disease. So if we visit a laboratory with a biosafety level 1 standardization, we will find people using a personal protective equipment, and more or less that is enough. You are working with the agent, you have to protect yourself, and that is more than enough. But when we move to biosafety level 2, we need further protective measures. One of the measures is what is known as biosafety cabinet. Now, what is the role of biosafety cabinet? If we place the clinical sample or whatever test we are doing within the cabinet, the air is sucked in, you do not get exposed. Okay. Now let us look at biosafety level 3 and 4. I think you would have seen some of the movies in which people are working in laboratory suited up like astronauts with specifically dedicated air intake vents. Those are the biosafety level 4. That means completely isolated. So if we need to handle biological agents, we should also need specific laboratories in which we can handle specific things. Okay. For example, like Ebola virus. I think if you have heard about Ebola, or say smallpox. Why smallpox is very dangerous now? The virus is still present. It is kept in some of the laboratories. But the people all over the world have got no immunity against smallpox. If a single person now gets infected, he will spread to each and everybody in the world. And with 99% infectivity and now with no immunity, about 70% mortality, it can cause havoc. Furthermore, it can infect very quickly because of airborne. So if I need to handle those kind of virus, I need biosafety level 4 laboratory. Otherwise, I cannot handle. But suppose if I need to handle a common agent which is very commonly available, and if I don't have any cuts, if I wear my personal protective like gloves and aprons and all these things, I will not get infected. I can handle them in a lab with biosafety level 1 specifications. Okay. Why I am telling you all this? Because further on you will learn about many of the diseases are caused by some agents which are more infectious, and some agents which are less infectious. So before sending any test to the laboratory for confirmation, you should be aware whether that laboratory can actually handle that agent or not. Have you understood? It's not like that, oh, I think this could be anthrax, let's send a sample to the nearby laboratory. Even they don't know how to handle it, and it will lead an outbreak. There are specific regulations about how these should be handled, both international and national regulations. Now, next comes the question why we are doing all these things. I have already told you we need to identify, treat for the patient's sake. Furthermore, we need to do for surveillance and outbreak investigation. When one person is affected, we need to diagnose and treat the patient. But if many people are affected, we need to find the source and how to control the outbreak. Otherwise, what will happen? The outbreak will become epidemic, and the epidemic may become a pandemic. And finally, we need to do control measures. For all these things, we need laboratory diagnosis. Next question comes, how to do it? The first thing that we need is specimen collection. That means we need to take something from the patient's body. Then we need to do the test either directly or indirectly, or we need to do culture. Then we need to identify it. Then we need to test against which drugs they are effective. That means which drugs are effective against that particular agent. Then other methods like serology and molecular methods are more conveniently used, especially for agents which cannot be cultured. This is how we do. So the patient comes, we take a clinical sample from the patient, we try to identify what exact agent is causing and therapeutic agent we can give to the patient so that it can be cured. These all have been taught, I guess. What are commensals? Any idea? একজন করে বলো। Anybody? What are commensals? They do not harm each other. And what if one agent harms the other? If it gets a benefit, we call it as, if it gets benefit, one gets benefit, it called sapro. If both get benefit, we call it as mutualism. Then if one harms the other and also gets benefit from that, we call it as parasite. Then what will be the colonizing flora? When microbes exist on the body surface, on the surface, it may be external, it may be mucosal. Mucosal surfaces are also internal. Then they are called as microbiota or commensal flora, or colonizing flora. Now they are present on the external surfaces. Normally they would not cause any disease. However, if they gain access into the body, it can cause disease. Understood? It may be present on the surfaces, external or internal. As long as it is present on that particular area, it will just remain over there. For example, some bacteria are present on your skin. It has been present throughout your life. It has never caused any problem to you. But if it gains access into your bloodstream, it can cause serious disease. That is what we call it as colonizing flora. Now, That means the human body is not alone in this environment. The human body is present with many other biological agents with whom we have various types of relations. Some may be colonizing the body, some may colonize the intestinal mucosal surfaces, break down some carbohydrates, let us absorb some of the vitamins. That is, mutual benefit is there, and some of them can actually cause disease. That is, they become pathogenic organisms. So these relationships are not fixed. They may change over time. They may change over the status of the immune system of the human body. If the immune system is strong, a bacteria might be present only as a colonizing flora. But if the immune system of the same person decreases, the same organism might become pathogenic. Now, when I say pathogenic, we need to know two terms. Organism which has been demonstrated to have the ability to cause a disease is called as a pathogen. So, what is a pathogen? As the name suggests, patho means pain or disease, gen means genesis, that is which causes it. So pathogen means organism which has been demonstrated to have the ability to cause infections. If an organism produces disease on occasions, not always, in some particular conditions, we call them as potential pathogen. And if an organism, potential pathogen is described as opportunistic if it produces infections in individuals who have compromised defense mechanisms. Then we call them as opportunistic pathogen. Okay. So based on that, we can divide the organism into three types: a pathogen, a potential pathogen, and a opportunist. Let me explain. In the same category, let us say, I think you would be acquainted with some of the bacteria, or no? Let us take an example of a bacteria, with bacteria A. Now this bacteria, whenever it gains access into the human body, it will cause disease. This is a pathogen. Okay. Another type of bacteria, say bacteria B, it is also present in the nasal mucosa in the body. Normally it will not cause disease. But suppose the patient goes for swimming, drowns, then comes back, and because it aspirates some of the swimming pool water, the bacteria gains access into the lung, it causes full-blown pneumonia. That organism we call as a potential pathogen. So normally it would not cause pneumonia, but if somehow it gains access into the lung architecture, it will cause pneumonia. And when we will call it as opportunistic pathogen, say another bacteria which will not generally cause pneumonia, but if a person who has, say, HIV, I think you have heard about HIV, the immune system is disrupted. So in those patients, a particular bacteria causes pneumonia. But in normal human being, it will not cause. Then we call them as opportunistic pathogen. Now, why I am telling you all these things? Because whenever we are receiving a sample to test for a particular pathogen, we must know the clinical condition of the patient also. Based on that, we will actually look for, what am I looking for? Am I looking for a pathogen, a potential pathogen, or an opportunistic pathogen? So if you don't give me the details, I won't know it, right? Similarly, if you don't know what are potential pathogens and what are opportunistic pathogens, you will also not think of it, right? For example, say you are in a clinic and you think the patient is having pneumonia. You have to look for whether the patient is having any immune suppression or not. If the patient is having an immune suppression, you have to think of opportunistic pathogens also, right? Okay, so as far as the diseases are concerned, some of the definitions, I think you know most of them. One is a communicable disease. Then what is a contagious disease? What is the difference between contagious and communicable disease? Malaria is a communicable disease or contagious disease? Is it contagious? You need the mosquito to bite from patient with malaria to other, right? If you go and hug a patient with malaria, you won't get malaria. But if you come in contact with a patient who is having measles or say chicken pox, you can directly take the virus from the patient. Then we call it as contagious. Try to understand the terminology. Then is iatrogenic. What is iatrogenic? Iatrogenic means when we as doctor try to intervene or try to do something to the patient and it results in an infection, we call it as iatrogenic. Okay. For example, suppose if a person has donated a blood and we have malarial parasite in the blood, and I transfuse the same blood to another person. Now that person have got malaria. Okay. Then what are nosocomial infections? Nosocomial means, nosos means in hospital or in care. Earlier, whatever infection that was acquired in hospital were called as nosocomial hospital. Furthermore, the naming was changed to hospital acquired infection. Now it has been changed to as health care associated infections. Why it has been done so? Because in today's time, not all patients are always admitted. Some of the patients will be coming to the clinic, they will be staying for a day and they will go back to the home. Even they will get some of the infections which they would not in most of the time at the home. So all those infections are also covered. So currently the exact terminology would be health care associated infections. Now look at this picture. This is the diagnostic cycle. So what is this diagnostic cycle? In the first phase, or it is called as the pre-analytical phase. When we do the test, we call it as analysis. So something that happens before the analysis is called the pre-analytical phase. Something that happens during the analysis, we call it as the analytical phase, and something that happens after the analysis, we call it as the post-analytical phase. So what happens in the pre-analytical phase? The patient comes to the physician with the complaints. Then the physician thinks that this could be an infectious disease based on the signs, symptoms, history, and he advises for laboratory testing. And based on the test, appropriate sample will be collected, transported to the lab for the testing. This thing happens in the pre-analytical phase. The next part comes is the analytical phase, in which the proper test is being done. At this point of time, a presumptive report can be issued or may not be issued, or a preliminary report can be issued or may not be issued based on the type of the test, based on the presenting scenario. Sometimes we issue presumptive report, preliminary report, but one thing is constant, that is for every test we have a final report. After that, we give the reports. When we give out the reports, after that comes the post-analytical phase. In post-analytical phase, what happens? The physician interprets the test reports and institute appropriate therapy and then follows up the patient. So this is the diagnostic cycle. Okay. So in short, there will be three phases: pre-analytical phase, analytical phase, and post-analytical. Now, in pre-analytical phase, after the patient visits the doctor and the doctor advises for investigation, the first step would be to take the sample or specimen. Now, what is a sample or specimen? What is a specimen? What do you think a specimen should be? Blood. Anything else? Urine. Anything else? Mucus, stool. Anything else? Saliva. Okay. CSF. Anything? So specimen is basically any part of the human body or body fluid. It could be urine, it could be CSF, it could be blood, it could be any sort of secretion like sputum, it could be an exudate. If you have an abscess, there is an exudate. It could be an exudate. It could be even body part. A surgery has been done, a body part has been excised, and it has been sent for investigation. It could be even external part like skin, hair. Okay. So any part of the body or body fluid can be a specimen. Now, when we are trying to decide for the specimen to send for investigation, some important fundamentals you should always remember. The first is the material must be from the actual site of infection, collected minimum contamination from the adjacent tissues, organs or species. What have you understood? Suppose a patient comes to you and says, I have pain and swelling in my left axilla. You examine that and you think there is a soft tissue abscess. Okay. So what do you think? It's an infection that is going on. What do you need to send? You need to aspirate from the abscess, take the pus out and send it for investigation. So first requirement is that you have to take the sample right from the site where it is being affected. You cannot go and look at, oh, here is the pus, let us take the sample from the adjacent lymph node. No. You have to hit where actual infection is. You think actual infection is there. If a patient is coming with sore throat, you need to take a throat swab. You cannot go say, okay, give us sputum sample. No. That is the first and most important part which will dictate what kind of sample you are sending for investigation. Okay. Second part would be to take it as cleanly as possible, because human beings have microbiota or colonizing flora everywhere. Even if there is an abscess within the soft tissue, if you are trying to take the sample, you should have to maintain aseptic process. Otherwise, your sample will be contaminated by the colonizing flora. You will end up treating a bacteria which is not causing the infection. So, you will be mistreating. Next important part is optimal times of collection of specimen must be established to provide the best chance of recovery of positive microorganisms. Let us take up the same example. Now this patient with the axillary abscess comes to you and the main complaint is that he is having pain. You need to give him antimicrobial agents. Now what will you do? Whether you collect the specimen first or you will advise the antimicrobials first. Why? Exactly. If suppose you have administered the antimicrobial agent empirically, and you are right, the organism will die. So if the patient had already taken antimicrobial agent, the chances of obtaining the organism will be very less. It will end up in a negative result, right? But keep in mind, in some infections, this cannot be always followed. Like for example, meningitis. It's a medical emergency. At that point of time, we are trying to save the patient first. Okay. So if it is a non-emergent situation, we need to take the specimen first and then give antimicrobial agents. Next is, we need to obtain the specimen in sufficient quantity. Why this is important? Let us say there is a big abscess, we have taken the syringe with a needle and you have tried to aspirate and you have taken very tiny amount. So in all probability you will get a negative result. So you need to take what is known as the minimum amount for a particular test. Like in pathology, for a simple test like a blood count, you need certain minimum amount of blood to do the test. If you have sent say 50 microliter of blood, you would not get any result. So always keep in mind, you should also take an appropriate amount of sample. Next, now we are dealing with microorganisms. These organisms are viable. They can be contaminated by the environment. So for each and every specific type of sample, we need to send them in specific type of collecting materials. Okay, it's not like that one universal container is there, whatever you get, put it inside and then send it. It cannot happen like that. You need to maintain the aseptic process and you need to take proper specific sample collecting materials for that. It could be a swab, it could be a syringe in which aspirated sample being sent, it could be a sterile container, it could be a non-sterile container, depending on the types of the sample, which we will look later on. Next is, whenever possible, you should always try to obtain culture. Let us look at it in a different way. Say a patient comes with a pneumonia, it could be streptococcal pneumonia which is causing pneumonia. You can go for a culture, you can go for a serological diagnosis or antigen diagnosis, which will provide you a better outcome in terms of patient management, an antigen test or a culture and drug susceptibility test. Why? Because see, a serological test or a molecular test will either confirm your diagnosis or exclude the diagnosis. But a susceptibility test result will dictate your management. You have made the diagnosis, okay, fine. What next? You need to treat the patient, no? So whenever possible, try to take the sample from which culture can be taken and drug susceptibility testing can be done. Another important part is smear should be performed. Later on, when you will be learning more about types of bacteria, you will learn some of the bacteria which are very difficult to grow in culture or does not grow in culture at all. For those organisms, microscopy is very important. So always when you are sending for culture, always advise for microscopy. Sometimes there will be many infections of polymicrobial. Polymicrobial means caused by many microbes. There might be aerobic organisms, might be anaerobic organisms. In the clinic, the doctor does not know which type of organism is causing the disease. But he has to keep in mind, if he sends for smear and culture, then in the laboratory, a laboratorician can corroborate between the smear result and the culture result. Some may grow, some may not. So always send for smear. If you look at a microbiological investigation commonly, you will see pass for gram stain or this stain or microscopy and for culture. The why this microscopy is important. So in culture we may miss someone. Next important part is, this is very important, not restricted to microbiology only, but for all. That is, whatever you are doing, label it properly with the patient's name, patient's identification number, what is the source of the specimen, what is the probable diagnosis that you are thinking of, when, date and hour when the sample is collected. All these things should be mentioned. Now you tell me, what will happen if these things are not mentioned? First, if you don't mention the patient's name and identification number, it will be mismatch. That is a negligence. Next, if the source of specimen is not mentioned, what will happen? Exactly. For example, you might send a specimen and have written pass for culture. Pass from where? Whether it's from scalp, whether it's from foot, whether it's from abdomen. It could be deep-seated abscess, it could be superficial abscess, it could be anything. Everything will have a different causative agent. Everything will have a different reason of causation. If you don't mention the site and the probable diagnosis of the patient, how will you know? I'll give you an example. Normally, abscess means it is rigid, swelling, painful, red in color. That's how we observe the abscess. Commonly, this abscess is caused by common bacteria. Tuberculous bacilli, there is a bacilli, tuberculous bacilli, which causes chronic infection. In an immune competent person, it will cause a chronic ulcer, not abscess. But if the patient is, say, immune compromised, for like an HIV infected patient, it may cause a abscess which may mimic staphylococcal or a pyogenic abscess. So if you don't mention the clinical condition of the patient, will I think of the? Obviously not. So it is always, keep in mind, always mention the site of the infection, site of the specimen, and the patient status, that is the provisional diagnosis and the patient status. Next important part is, you have to send this specimen to the lab. Sometimes the lab is very near, like in a, say, a medical college and hospital, the lab and the hospital are very close to each other. It can be easily sent. Sometimes the hospital is at a distant location from the laboratory. The organism might die during transport. So many a times we need what is known as transport medium. What is a transport medium? It is a culture media which preserves the organism. It does not let it die during the transit. Then in the laboratory, the specimen is received. Now what will be the actions from the laboratory part? All the patient details should be collected. The specimen should be scrutinized whether it is being properly sent or not, whether an appropriate sample is sent for this test or not. We'll talk about appropriate sample or rejection criteria later on. Keep in mind, not all specimens are used for all kinds of tests. We can do some test for some specimen, some test we cannot do for some specimens. So this has to be checked right on the reception of the sample. Okay. Then the laboratory worker should have their own personal protective equipments and taking universal precautions. Thereafter, examination is started. First is visual examination of the sample. I think you have heard about macroscopic examination. Then We look it under the microscope. That will be the microscopic examination. We can go and do different type of staining methods, look for particular organisms, or we can do various types of wet mounts or pigment methods, like a hanging drop preparation or an iodine mount or a saline mount, and look under the microscope. Thereafter, we have to go for the culture and drug susceptibility and further test, which we'll learn in subsequent classes. Have you understood till now what I am talked about? So you have learned something about something is called as infectious disease and how we need to proceed to diagnose it. Okay. Next part, we'll talk about some important samples that you should know to collect. The first and most important is what is known as blood culture. Now, what is blood culture? Blood culture means we are taking a part of the blood that is circulated in the cardiovascular system of the patient, and we are culturing that part of the blood so that we can get the organism that is causing the disease. Now, what will be the disease in this case scenario? It is called as sepsis. Sepsis means it's a process in which an organism that gains access into the bloodstream and causes disease, that is organ dysfunction. So what will be the aims of the blood culture? To confirm the presence of microorganisms in the bloodstream, to identify them, and to test for the susceptibility so that we can kill them. Okay. Now for blood culture, we need to send the blood in some bottles like this. Then there will be a very important question: what is the normal amount of blood that is present in an average Indian male or female? 4 to 5 liters will be a better answer. So, what amount of blood do you think we should take for culture? The more the merrier. The concept is very simple. What would be the minimum amount of blood we should take for culture? Why 20 ml? What would happen if I take, say, 500 ml? So what will happen? I will get a better outcome in my test. Say patient has 5 liters of blood and say there are 1000 bacteria in the whole body. So if it is distributed evenly and I take 500 ml of blood from that patient, I have a higher probability of getting the bacteria, right? And you have a lower probability, you are saying you will be take only 20 ml. So I have a higher probability. Then why should I should not take, say, 500 ml? Okay. Now let us say if I take 250 ml. If you have donated blood, I think 1 unit is around about 250. So people can donate the blood. That will not change the homeostasis. So if I take 250 ml for culture, that would be still better than 20 ml. Absolutely correct. Keep this in mind. There will be many concepts that you will learn. Sometimes people will say it is the best to take the blood before the fever comes or during the fever comes. That will be very appropriate. The most important factor which determines whether your culture test will be positive or negative is the amount of blood. Okay. Depending on the type of infection, we will have to take different types of blood. For example, in sepsis, that means the organism is constantly in circulation of the blood. 2 to 3 sets, I'll come to it, sets is enough. But for example, a disease called infective endocarditis, what happens is that in the heart valves, the organism is present in vegetations. The organism is spreading from those valve vegetations into the bloodstream intermittently, not a continuous, intermittent. To get a culture positive in that case scenario, we need to take more number or more sets of blood culture so that we can get it positive. Okay, so always keep in mind it will depend on the provisional diagnosis. That is the reason why always mention the provisional diagnosis. Okay, so normally it is done so that a bottle will have about 20 to 30 ml. 1:5 to 1:10 dilution should be maintained in the bottle, because blood itself has some properties which inhibit growth of microorganisms in the first place. Furthermore, the patient may or may not have taken antimicrobial agents. If those are present in the blood, the bacteria is unlikely to grow. For that, we need to do as dilution. As of now, keep in mind about 10 to 20 ml is sufficient. But for two sets means a pair of aerobic and a pair of anaerobic blood culture. Recently, it has been advised, because anaerobic infections are less common. The people say that you send 2 sets of aerobic only. Okay. Now, how to take blood culture? Blood for culture. Keep in mind, this is an aseptic process. Proper aseptic materials method should be followed. Okay. So, what would be the proper method? First is, after you locate the vein, wear the gloves, then clean the area first with alcohol, that is the skin over the vein. Use either chlorhexidine or povidone, that is tincture iodine. Let it dry, then remove it with alcohol again. Then use sterile gloves, puncture the vein, draw about 10 to 15 ml of blood, and directly inject the blood from the vein, from the syringe into the blood culture bottle. Okay, I'll show you a video. Okay, just two important part is that how to transport the blood culture bottle. It should be sent to the laboratory within 4 hours. These things please do not refrigerate. Many people will have it, okay, I can't send it right now, keep it in the refrigerator, I'll send it later. No, the organism will die. Then whatever bottle that are using, you should always look at the expiry dates, when should be used and when not should be used. According to the manufacturer guidelines, or it's a conventional method, you should ask the laboratory itself who is sending you the bottle. And obviously, if you don't label it properly, or if the bottle gets broken or damaged, it will be rejected. So take proper precautions so that those things don't happen. So this is a video that is also in YouTube by Biohazards, a company which makes automated blood culture system. So what are the things that we need? We need blood culture bottle, and okay. So what are the things we need? I think you can see we need blood culture bottle, we need syringe, we need gloves, we need tourniquet, and we need to maintain aseptics. So after taking the bottle, you must look at the expiry date, the lot number, check whether this bottle is appropriate to send for culture or not. ठीक है, ऐसा नहीं कि पहले ही जाके ब्लड खींच लिया, पहले इंश्योर करना है कि मेरे पास सब सामान है कि नहीं और जो बॉटल है दैट इज यूजेबल और नॉट. Then most important, before any aseptic process, you have to maintain what is hand hygiene. I think hand hygiene, you know. Okay. After that, this is used for patient identification so that there is no mismatch of the sample with respect to the patient. After opening the cap of the bottle, what the person is doing, he is cleaning the hub of the bottle with alcohol. This will further maintain sterility of the bottle. If you don't do that, what will happen? If inadvertently you touch the top of the bottle and then you inject the syringe, you are introducing environmental bacteria into the bottle. That is, will end up contaminating the bottle at the site itself. The vein was palpated. The person who is opened got had done hand hygiene, has worn proper personal protective equipment. You can see the gown and the gloves. Next, what he is doing is using alcohol rub on the skin over which the vein lies. And how will he or she do it? In a way that is in circular movement away from the center. Suppose this is the elbow region, okay? So we need to disinfect it from center to away. Not crisscross, not haphazard, only in this way. Reason is very simple. When you first touch, the alcohol content is highest. So at this area, asepsis is highest. The more you move around, asepsis will be less. So once you touch the inside, you do not go back on the same area. Understood? And after, obviously, after doing that, do not touch the same area. Now, what would be the second disinfectant? The first one that was applied was alcohol. The second one could be either chlorhexidine or it could be iodine. Just keep in mind two things. Chlorhexidine can be used for any patient more than 2 years of age, but you should not use chlorhexidine for children less than 2 years of age. If you are using chlorhexidine, it is not a vein irritant. You don't need to clean it after using it. But if you are using iodine solution, iodine is an irritant. So when you apply the iodine, let it dry, then remove the iodine with alcohol. Otherwise, there will be thrombophlebitis. Okay. But if you are using chlorhexidine, you don't need to remove it because it does not causes inflammation. Then the vein is punctured and blood is collected. If you get an this apparatus, you may discard the needle through which you have taken the blood. If you don't have the apparatus, many a time that happens in our conditions, we use the needle itself to puncture the bottle and to inject the blood that is in the syringe into the bottle itself. Okay, just keep in mind, when are you handling this, handle the syringe and needle very carefully. Otherwise, chances are you yourself will get pricked with the needle. Okay, so this is the reason why in this video they have shown that after taking the blood, they have discarded the needle and used this kind of an apparatus to inject the blood in the bottle. So this is how the blood is injected into the bottle. Thereafter, proper labeling is done, either printed or handwritten. Then proper packing is done. I'll come to it later. And then sent to the laboratory. Okay. So this is how blood for culture should be taken. Now this was one of the very important samples when we are considering sepsis, that is infection of the cardiovascular system. Another important system in which infections are very common is the urinary tract. Now the urinary tract we basically mean from kidney to the urethra. So if there is infection of the kidney, we call it as nephritis. If it involves the pelvis, we say pyelonephritis. If there is the infection of the ureter, we call it urethritis. If it is the infection of the bladder, we call it as cystitis, and similarly urethritis. All these come under the purview of urinary tract infections. So for urinary tract infections, what will be the sample? For what? Urine for what? Okay, let us look over here. Suppose if there is pyelonephritis, will you get the organism very quickly in the urine? No. For that, the best option would be if we can take a aspirated urine sample from the kidney, or something what is called as nephrostomy sample. That is, a surgical procedure is done, and during that process the urine sample is taken directly from the pelvis of the kidney. Okay. Next would be the bladder. The most commonly it causes cystitis. So from the bladder, how can we take the urine sample? The easiest method is we ask the patient to void urine. We'll get the urine. But what is the problem with that urine? The urine comes out through the urethra. The urethra is in contact with the external surface. The external surface has colonizing flora. So if the person voids, what will happen? The urine will have both the pathogenic organism and the colonizing flora. Have you understood? Any other method by which we can take the urine from the bladder? We can put a catheter in it. This is called as straight catheterization. Or the patient may have catheter inside the body beforehand for other cause, maybe a surgery or any other condition. We can take the urine from the catheter itself. That is called catheter sample. And finally, we can aspirate the urine from bladder itself. This is called suprapubic aspiration. We take a long needle, puncture the bladder and take the urine out. If these are the all ways by which we can take the urine, what is the most easiest and safest way? Obviously, to ask the patient to void. And what will be the most painful way? Suprapubic aspiration. Now tell me, what is the best urine sample for culture? Why? Exactly. So even if a single bacteria is present in suprapubically aspirated urine specimen, that is the causative organ. But it is not generally used. Why? Because it's a painful process. Okay. Painless process is midstream urine, but problem with midstream voided urine will be contamination. This is the reason why there is a concept called as significant bacteria. I am just giving you the logic behind significant bacteria. In your urinary tract infection classes, I will explain it furthermore. The logic is that if a bacteria is causing infection in the bladder and the person has given a voided sample of urine, the number of bacteria in the colonizing flora of the urethra will be less in number as compared to the bacteria which is causing infection. Have you understood or not? Yes or no? Concept is very simple. If some organism is causing an infection, the number of that organism will be higher as compared to something that is present inherently like a microbiota or colonizing flora. This is the concept of significant bacteria. Okay. Further details we'll discuss later on. I'm just giving you the concept. And finally, urethritis. Many sexually transmitted infection can cause urethritis, and for urethritis we can take either early urine sample, that is the first urine sample, or we can take a swab sample from the urethra itself. So these are the commonly methods: suprapubic aspiration, straight catheterization, and the sample that is taken in a container. This is called universal container, and it's a sterile container. The most important aspect of this container is this is a sterile container. It is packed in a plastic packet, and when the patient will open this container, when he is trying to void the urine, start urinating, will not stop urination. During urination, will take a midstream, that is on the middle part of the urine. Why not the early part? Because urethral contamination. Why not the terminal part? Same, urethral contamination. Next important would be central nervous system. Most important infection is meningitis. Meningitis means infection of the meninges. Between the meninges, that is between the pia mater and the arachnoid mater, there is something called as cerebrospinal fluid. So if something is irritating the meninges and causing inflammation over there, that organism is bound to be present in cerebrospinal fluid. Commonly, CSF is collected by a process known as lumbar puncture. Please remember, this is a sterile process. All sterility should be maintained, otherwise you will be inoculating or introducing organisms into the cerebrospinal region of the patient, and you will be causing what is known as iatrogenic meningitis. So briefly, what is this process? The patient is put in a left lateral position and is asked to pull his knees close to his chest. What will it do? It will increase these spaces, that is the L3, L4 and L5 spaces. That is the region where the spinal column ends, but the meninges continues along with the cerebrospinal fluid. At this point, with a spinal tap needle, CSF, the needle is introduced into the gap between the vertebral bones and CSF is collected. Now keep in mind, when you are collecting CSF, you should collect in 3 tubes, 3 samples. The first one is for cell count and differential stains for microscopy. The second one would be for microbiological investigation including culture, and third part will be to analyze proteins, cells and for biochemical analysis. When we'll discuss about the CNS infections, we'll go into the details of why glucose is estimated, why proteins are estimated. Just keep in mind, for cells we need one sample, for culture we need one sample, and for biochemical analysis we need one sample. So at least 3 tubes should be taken. Next is a pus sample. I have already I think told you, any kind of pus, the best sample would be an aspirated pus. This is also a try to maintain asepsis as much as possible when you are trying to aspirate. That is, you must clean the skin with alcohol and chlorhexidine or iodine like in blood culture, and then go for aspiration. And when we are trying to aspirate, we aspirate whatever material that comes out in the syringe, and we send the syringe itself, but not with the needle, because that is a risk of needle stick injury. Another way the pus sample can be sent, if a biopsy is taken, either post-operatively or a punch biopsy, whatever method that is being used, that tissue specimen can also be sent itself. But keep in mind, it should not be sent in formalin. For pathological or histopathological examination, we send the samples in formalin. But if you put formalin for culture, formalin will kill every organism. Okay. For that, we need to send the tissue in saline, that is the normal saline, not in formalin. Third way is, if it's an open wound or an ulcer, we can send the swab. For that, we need to clean the superficial part of the ulcer or the open wound, let the secretion or the serous fluid that comes out, and if any pus comes out, we collect that with the help of a swab and send this swab for culture. Among all these, perhaps swab is not the best method of sample collection. Among other swabs, there are two important swabs. One is nasopharyngeal swab and is a oropharyngeal swab. How many of you have been tested for COVID? So you have the personal experience of giving swab sample. Now nasopharyngeal swab is predominantly taken for upper respiratory tract infections. Most of them are caused by viruses. And how it is taken? The patient is asked to tilt the head, and the swab is introduced along the floor of the nostril, not towards the head, along the floor of the nostril. Otherwise, you will be injuring the olfactory region of the nose. And next is oropharyngeal sample. When is the oropharyngeal sample important? Very commonly sore throat or streptococcal pharyngitis. And sometimes not so common now, but still important, is if you are suspecting the patient is having diphtheria. So you need to take the sample. How you need to take the sample? Ask the patient to sit down on a chair, extend the neck, and say ah. Right? Why? Because when you say ah, the uvula is lifted up, you can see the posterior pharyngeal wall. And while taking the swab sample, how will you take swab sample? You will take the sample between these arches, that is the tonsillar bed, the uvula, and then the posterior pharyngeal wall at last. If you touch the posterior pharyngeal wall at first, what will happen? The patient will gag. Okay. So you take the sample from one tonsillar bed, uvula, to the other tonsillar bed, and finally touch the posterior pharyngeal wall. This is how you take a throat swab. Next is stool sample. Stool sample can be tested both for bacteria, both for parasites. For stool sample, it can either cause diarrhea or dysentery, and we don't need a sterile sample, sterile container, because stool itself has millions and millions of bacteria. When we'll talk about diarrhea and dysentery, we will talk further how stool culture is done. But importantly is that we need to look for specific organism, we need to look for specific bacteria. हम ये नहीं कह सकते कि बताओ भैया इनके स्टूल में क्या क्या बैक्टीरिया है. We cannot do that. There are millions of bacteria. What we need to look for is the known bacteria which causes diarrhea or dysentery. The final aspect of sample collection is, you have seen in that video, that person has taken the blood culture and put it in a plastic bag and then sent it. Why? Because for proper transport of any clinical sample, I have already told you, clinical sample is a biosafety risk because it may or may not contain a biohazard substance, biohazard agent, right? So you need to take proper precaution before sending the sample. How the packing should be done? There is a primary receptacle in which the sample is kept. Then it is kept in a secondary package. This is the secondary package in which absorbing material is placed inside, so that if in any case the primary receptacle gets broken, the sample is absorbed by the absorbing material. Then on the body of the secondary package, you have to enlist what the primary receptacle contains, whose sample is this. Finally, you lock the secondary container and then send it in a tertiary container, which will be actually sent. Have you understood? ऐसा नहीं कि इसमें ब्लड लिया इसी को भेज दिया, इसको मुझे एक और कंटेनर में डालना है जिसके अंदर एक कॉटन पैडिंग रहेगा. So absorb if in an unfortunate event in which the primary receptacle gets broken. On the body of the secondary container, we have to give the details of the item that we are sending. What is this item that we are transporting, to whom it belongs, which test is intended for, how this test should be conducted, all details should be written. Then this secondary container should be packed in another container which is sent. This is 3-tier system of packaging. By this method, you can send a sample from hospital to lab and from any part of the world to any other part of the world. This is how the proper packaging should be done. Okay. So I think I'll conclude today's class till over here. So to summarize, I think we have learned that what are infectious diseases, why diagnosis is important, how to do the diagnosis, what are the phases, that is the pre-analytical, analytical and post-analytical phase. Important part of pre-analytical phase is sample collection, and we have looked about the most important samples of the common infections. Henceforth, we will look at the other aspects of the diagnostic cycle. Okay.